I want to thank you all for being here. Really appreciate having you here. And the first thing I want to do is thank someone who unfortunately couldn't be here. We are so grateful to the Meridian, the Gardens, for sponsoring the Family Education Series. And they're usually here and have a display, but they had an emergency and were unable to make it. So we really want to appreciate them. Additionally, we want to thank our community partners who are here today, from whom you can get a lot of information. Over there to my right, we have Alzheimer's Family Services Center, Christine, and then the Alzheimer's Association, Carrie's over here, separated from her table at the moment. And then back in the back, we have the Caregiver Resource Center. Karen is here. And then, of course, our UCI Mind table. So if you haven't had a chance to visit these folks, please do so after the presentation. I also want to make a couple of other announcements. I want to just invite you to the Ask the Doc forum that we are going to be having at Saddleback Church next Thursday afternoon from 1 to 3 o'clock. Ask the Doc forums are an opportunity for audience members to ask any question that they want of expert panelists, including Dr. Dick and myself and a couple of other folks here from UCI Mind. So if you've got more questions after tonight, come to Ask the Doc. Finally, I just want to mention you should have all received one of these Keep Informed cards. And even if you're already on our mailing list, if you decide you would like to participate in research or you would like some other kind of follow-up, make sure to fill this in and to hand it to one of our staff. And our staff in the back from UCI Mind are Marcelo Soares, our new education coordinator, Marcelo, who many of you spoke to on the phone. We have Susan, our senior psychometrist, and back in the back we have Ken, patient care coordinator, and also Peter, our clinic manager. So we thank everybody for all the help tonight. So with that, I think we can go ahead. Make sure to pay attention because I'm going to ask you to fill out the evaluation forms at the end. So tell us how we did at the end. Today's topic is the first of 4 topics that we're going to present over the course of a year. And this first topic is going to address Alzheimer's disease and other forms of dementia and describe them for you. On June 11th, oops. All right, this was working fine a moment ago, 5 minutes ago. This was working fine. Oh, I know what I did. Hey, here we go. On June 11th, we're going to be talking about treatment for dementia, both current treatments that are available as well as future treatments. In September, we'll be talking about how to manage behavioral symptoms such as agitation, wandering, suspiciousness, depression that commonly occur in Alzheimer's disease and other dementias, and talking about a variety of strategies to help you do that, as well as what is the appropriate use of medication. And finally, in November, we'll be doing a presentation on ways to reduce your risk for developing Alzheimer's and other forms of dementia. Well, this is always a fun way to get started. These are some folks that over the decades have had Alzheimer's disease. Most of them have passed away. A couple are still living, and I'm just going to point out the living folks. And do you know who that is?
Yeah, that's Tennessee basketball coach.
That's right, Coach Pat Summit. And the other living individual, that's a singer, Glenn Campbell. Right, and here's someone who died very recently. Does anybody recognize her? Dear Abby, absolutely, yes. And she just died this last year of Alzheimer's disease. Now there's some very familiar people. Reagan, okay. Going across, who is this? That's right. Jack Lord.
Hawaii 5-0.
Yeah, Hawaii, that's Hawaii 5-0, that's right. Who's this? Perry Como?
He's an actor.
Oh, I know that guy.
Help with a cue, Malcolm.
He was in a lot of
Malcolm's going to give a hint.
he was in a lot of the sort of B movies from the 1960s and 50s. Pat,
Edwin O'Brien.
okay, Pat or Edmund O'Brien.
Down here? Dana? Okay.
Dana Andrews.
Who's this? Yes, that's right. And then we jump over here. Who's that?
He was in War of the Worlds, the first one, 1953 or so. He was also played that. His name is Gene Barry.
Somebody said that, I think. And over here, David Niven. That's right. I heard that.
Charlie Bronson.
That's right. All right. Let's see. Who haven't we hit? Oh, who's this?
Arlene France.
That's right. Who's that?
I cannot see well.
He played Scotty on
He's
Star
on Star
Trek.
Trek.
Oh, Scotty.
Yeah, Scotty. What's his real name? Now I can't think of it. Okay, and then
James Duhannon.
yep, this one. Who's this famous painter?
Norman Rock.
Yes.
That's correct.
And then finally, right. So this is a nice icebreaker, but it also reminds you that any of us are susceptible to Alzheimer's disease. Alzheimer's is actually the most feared disease in the United States by Americans that are 55 and older. It's more feared than heart disease, cancer, and stroke. That was found by a recent survey by the MetLife Foundation. Also, unfortunately, 62% of Americans know very little about Alzheimer's disease. So there's a lot of misconceptions, and it's very important to come to presentations like this to gain a better understanding of what the disease is and how it affects people. Interestingly, there was also another survey done across 5 different countries. You see them listed on the slide there and also in your handout. And about 25% of all the adults in those countries said they fear Alzheimer's more than 6 other diseases, including cancer, stroke, heart disease, diabetes, influenza, and depression. And again, in this cross-country study, 1/3 of Americans most feared getting Alzheimer's disease. How many of you worry about getting Alzheimer's? Yeah. So it's a very, very common fear.
This is just a slide showing the impact of Alzheimer's disease in the United States. And
We're getting the music turned off, by the way, so Susan just went to do that, so apologize for that.
So in 2012, it was estimated there's about 5.4 million cases of Alzheimer's disease in the United States. Approximately $200 billion was spent in 2012 for Alzheimer's disease. That was the cost for care, for doctor's visits, for nursing homes. It's a huge amount of money, and if you look at the amount of money spent by the federal government through the National Institute of Health and Aging, it's about $680 million. So we've got $200 billion, and we're spending really pennies on this disease. It's the 6th leading cause of death in the United States, and every essentially 68 seconds, a new case of Alzheimer's disease is diagnosed, and by 2050, it'll be every 33 seconds, a new case will be identified.
So this slide basically makes a similar point, and this was based on the 2000 census, showing that from 2010 through 2050, we'd have a tripling almost of the number of people with Alzheimer's disease. Now, Now, it's interesting, there was another study that was just released, and that's based on the 2010 census, and it had some similar findings in that we're going to see the numbers triple to at least 13.8 million by 2050, so that's almost a 180% increase. But you see, the vast majority of the increase, or the highest percentage increase, is going to be in people who are 85 plus. So this is the total. The blue line is the 85 plus group, age 75 to 84. So you can see where eventually these 85 plus is going to grow faster than the 75 to 84 group, and then the 65 to 74 group is right there. So that's an 85% increase.
Currently, roughly, the United States has 1 out of every 10 Alzheimer's patients living in California. So we have 10% of the total number of Alzheimer's patients. In Orange County, it's estimated that there's approximately 60,000 cases of Alzheimer's disease, or individuals who are at risk of developing Alzheimer's disease, which is called mild cognitive impairment, which we'll talk about in a little bit. I see you shielding your faces over there.
Yeah, I think that's the
Is there
best they can
any
do.
way that we can cut down the glare? The number of individuals in California is expected to double by 2030. So right now it's over 630,000, and by 2030 it's estimated to be about 1.1 million cases, just in California alone. And of the baby boomer generation, and both Cordula and I are baby boomers, but baby boomers were the individuals born between 1946 and 1964. 1 in 8 individuals will have Alzheimer's disease, and 1 in 6 will have some form of dementia.
One of the things that's really interesting about this that Malcolm didn't mention a minute ago on this slide is you can see there's 15.2 million unpaid caregivers. So basically, you can see there are 3 caregivers for every person with Alzheimer's disease. If we have 1.1 million Californians affected by Alzheimer's disease, that means we have another 3.3 million caregivers who are also affected. It kind of gives you the real sense of the huge impact of this problem. So why do we have these escalating numbers of people with Alzheimer's disease? Well, one of the primary reasons is because we're living longer. And the older you get, the more at risk you are for the disease. Now, this basically shows you here life expectancy in Orange County, and we can see that life expectancy currently for all individuals in Orange County, all women, is 83.2, and for men is nearly 80 years old, and it's broken down by ethnic group. Interestingly, there were some census data again from this year that showed that for an individual like myself, we looked at 1940, I would have reached the age of approximately 48 before I passed away. Today, I'm going to reach well over 80 years of age. Why does this make a difference? Because the number of people with Alzheimer's disease basically doubles every 5 years after age 65. So you can see here, 1 in 20, or 5%, from 65 to 75. At age 70, 10%. At age 75, that's actually 20%. And then by age 80, we're talking about 40% of individuals being affected. In one seminal study that was done in 1989 now, but is illustrative of many, many studies that have been done that all show risk increases by age. You can see by the time you're age 85, approximately half of individuals are affected, and by the time you reach age 100, approximately 70% are affected with Alzheimer's or another form of dementia.
And we just We had just talked about how we're going to have a doubling of the number of individuals in California affected by Alzheimer's disease by 2030. It'll go up to about 1.1 million. The majority of those individuals, as you can see from the chart, are older adults, above age 75 and older. But we're also going to be seeing a doubling in the number of individuals who are 55 to 74. So as you'll learn, Alzheimer's disease is not just a disease of the elderly. It can affect individuals in their 40s and 50s and 60s. One of the interesting things about Alzheimer's disease is that it affects pretty much all ethnicities and all ethnic groups relatively equally. In California, the percentage of Hispanics, which is the second largest ethnic group after Caucasians, the percentage of Hispanics with Alzheimer's disease will triple by 2030. And the number of Asians with Alzheimer's disease will also triple by 2030. The number of African Americans will double. Well, why would the number of Hispanics and Asians be tripling? Well, if you just went back a few slides and you looked at the average life expectancy, you can see that the average life expectancy for Hispanic females and Asian females is actually a lot higher than for white females. So we know the older you get, the greater the risk of the disease, so that's going to be one factor. Another factor is related to education, particularly within the Hispanic Latino population, because approximately 1 in 10 Hispanics have zero education, zero formal schooling, and about 50% have less than an 8th grade. And we know that education is one way you can lower your risk of developing the disease. The better educated you are, the lower the risk. So individuals with very limited education are at double or more the risk of the disease. The other factor, both for Hispanics and Asians, is issues related to health, particularly hypertension, diabetes, and cholesterol. And that's also true with the African American population. Those individuals are less likely to be receiving medical care and having these health risks under good control, and that also increases their risk.
Well, what about here in Orange County? There was a study done in 2008 by the University of California, San Francisco, and the Alzheimer's Association, looking at the number of people with Alzheimer's disease across California. And that study showed that today, or 2008, I should say, about 47,000 individuals that have Alzheimer's disease. And you can see again that that number's, projected to double by 2030. Now, currently, the Alzheimer's Association estimates that if we add in all the people that are at risk for developing Alzheimer's disease, that would be people with mild cognitive impairment, we have at least 75,000 individuals affected with Alzheimer's disease or at high risk of developing it. So, again, we're going to see huge increases here locally, as well as statewide and nationwide in the number of people affected.
Well, as we mentioned in an earlier slide, Alzheimer's is the 6th leading cause of death in the United States. And in Orange County, for people aged 75 to 84, it's the 5th leading cause. And if you're 85 and above, it's the 3rd leading cause of death. So it is accounting for a large percentage of individuals, and these are relatively new numbers compared to what we used to think. And one of the problems in the past was when you looked at death certificates, the physician was only required to put the immediate cause of death. They didn't put all possible contributing factors. So, for example, you could have a patient who's been for the last 6 or 7 years in a nursing home with severe Alzheimer's disease in a fetal position who develops pneumonia and passes away, and the death certificate would just read pneumonia. And the fact that they had Alzheimer's that led to them being in a nursing home and led to them being very frail, that was not even counted. So now they count all possible causes, and that's why we've seen this sort of skyrocketing in terms of the actual realization that Alzheimer's is a major cause of death in older adults.
So this next slide shows you, illustrates just that point. Looking at the 8 years between 2000 and 2008, you can see that in terms of cause of death, there was a 66% increase for Alzheimer's disease. During that same period, look at all these other major diseases, there was a significant decrease in the percentage of cause of death. So part of this is what Malcolm said about, you know, we're doing better at counting Alzheimer's disease as a cause of death, but another important factor is that we've become much more effective at treating these diseases. The treatments we have for Alzheimer's disease are still what we call symptomatic. They can help the person, but they can't change the course of the disease, and they're certainly not a cure.
Because there's some confusion about distinguishing normal memory loss from mild cognitive impairment and Alzheimer's disease, we thought we'd spend a few minutes just talking about some of the differences between these disorders.
So do you ever scratch your head when somebody says, oh, Alzheimer's disease, dementia, mild cognitive impairment? One of the most common questions we get asked is what the difference is between these things. So we want to help you understand that. So dementia has three major characteristics. And the best way to think about the term dementia is as an umbrella term. And the three characteristics are loss of intellectual ability. Number two, it affects your memory, plus one or more other cognitive abilities. So that might be language, reasoning, judgment, your ability to find your way around in the world, or what we call visual spatial abilities. And the third characteristic is that the impairment is so severe that you can't carry out your normal daily activities anymore. At first, you might have to give up working and driving, but eventually you have difficulty taking care of your own most basic needs. So that's dementia. It's an umbrella term, just like cancer is an umbrella term. There's a lot of different types of cancers: breast cancer, lung cancer, cervical cancer, and so on and so on and so on. They're all types. The same thing with dementia. Dementia is a syndrome. There's different types or causes. Alzheimer's disease happens to be the number one type or cause of dementia. So how do you move from normal aging into Alzheimer's disease? Well, you don't just fall off a cliff, okay, into Alzheimer's disease. There's a slow, gradual progression. And in the last 15 or so years, researchers have defined this transitory phase, or this phase where you're transitioning from what we consider normal aging to Alzheimer's disease or another dementia, as mild cognitive impairment. We're going to describe that in more detail, but it's really a borderland between normal aging and Alzheimer's disease or another dementia.
So the new conception about Alzheimer's disease is that it's a disease that is decades in the making. So as Cordula said, it just doesn't happen overnight or in a year or two. The initial changes are probably occurring a decade or more before any actual symptoms become present. So this phase of the disease where there's changes going on in the brain, but there's no obvious symptoms such as memory loss or language problems or confusion, this is called the pre-symptomatic stage. When symptoms become evident to other people and the individual themselves, so the memory loss is present, the language is there. When these symptoms become present, that's when we call them mild cognitive impairment, but the person is still able to do most of their activities of daily living pretty independently. So they can go out and shop, they can pay their bills, but there's definite problems with their thinking. And then, as Cordula said, when you get into the dementia, now the person needs assistance with their functional abilities. They can't shop, they can't drive. They need assistance doing a lot of these everyday living skills.
So there's a long silent period of this disease when you might have it and not know it. So I always tell people, you know, I'm 58 right now and I could have Alzheimer's disease. I could have had it for a decade already, but not know it yet. And we're going to get back to that because we're going to talk about research efforts to try to identify the disease earlier. So, but what does healthy aging in terms of cognition looks like? We all are going to experience some cognitive changes as we age. So, some of the things that I'm aware of that have changed, and you probably have too, is that it's harder to remember new information, particularly things like names, right? So you really have to put a lot of effort into learning something new. You have to pay attention, maybe use some strategies like visualization to help you remember. Sometimes you can have a little more word finding difficulties, so that tip of the tongue phenomena, which will probably happen to me sometime during these 2 hours where I'm looking for a word, it's on the tip of my tongue, and it comes back to me an hour later, right, when you don't need it anymore. Also, become much more susceptible to distraction. I grew up in Oregon on a little tiny farm, and we were quite poor, and so my desk where I studied was in the same room where my brother watched television, so I was able to very easily insulate myself and block out the distraction. But these days I can't do that anymore. I have a radio in my office, and if I'm on the phone or something else is going on, I have to turn that radio off or I'm not going to be able to focus and pay attention. And it becomes a little bit harder to multitask, do multiple things as once. So all of this is normal. And so we're going to talk about the subtle changes that occur and also sometimes how difficult it is to differentiate between what's normal and what's going on into mild cognitive impairment.
So in the preclinical phase, as I mentioned a moment or two ago, this is where there are actual changes going on in the brain, but there's no obvious overt symptoms present. And this preclinical phase can be where there's no symptoms present, such as where the green and the blue lines are merging, to where there's very subtle symptoms that are hard to distinguish between the preclinical and the normal aging variant. And oftentimes in the preclinical stage, individuals might be complaining about problems with memory, that their memory is changing. They know something's going on because they're not as good as they used to be, or they're having more difficulty with word finding, or they're getting confused about where they are when driving. This preclinical phase could be due to a lot of other causes, however. It could be a preclinical phase, or it could be due to things like depression, anxiety, stress. So this is a phase that a neurologist, Barry Reisberg, who's at New York University Alzheimer's Center, he calls it a stage where the person knows that something's wrong, but the doctor doesn't. Because if the doctor gives you standardized tests of memory or thinking, the person scores in the normal range, and the doctor would say, well, you're fine, but the person says, well, but something doesn't seem quite right. This pre-symptomatic stage is not unusual in medicine. There's lots of disorders. So for example, in the pre-symptomatic stages of heart disease, there could be cholesterol building up in your artery walls. That is gradually narrowing the arteries. There's no obvious symptoms, but we know when we can measure that there are these changes going on in the artery walls, and eventually it might lead to a heart attack or a stroke. The areas that seem to be affected in the brain, and this is, I usually have a model of the brain, but I forgot to bring it with me. It tells you about my own brain. But a real brain it's about 2.5 to 3 pounds in weight. Your head might weigh 20 pounds, but the brain is a relatively small portion of that weight. And it's about the size of a medium cauliflower, so you can sort of hold it in your hands. But within this gelatin mass of about 2.5, 3 pounds it's estimated we have around 100 billion brain cells. And as each brain cell can have connections to as many as 7,000 other cells, you end up having around an estimated 100 trillion connections. So in this very small structure, it's a very complex network of cells. An area that's affected early in Alzheimer's disease and in mild cognitive impairment is a region of the temporal lobe. The temporal lobe just lies a little bit above where your ears are. And this structure that's particularly important is called the hippocampus. And the hippocampus sort of extends through this temporal lobe. And the hippocampus is very important for the processing and encoding or storing of new memories. And this is an area affected very early in Alzheimer's and in mild cognitive impairment.
So this illustrations right here portray what happens in the brain, and again, this is real human brains, a side view like this. Okay, so this is the temporal lobe, and it's right over your ear. Malcolm was just pointing to it earlier. This is a healthy brain at autopsy, and you can see here the folds in the brain are very tight and close together. Now in the person with Alzheimer's disease, you can see the changes that have occurred primarily again in the temporal lobe, also some in the frontal lobe, as well as here in what we call the parietal lobe, and the large amount of atrophy that has occurred where there has been death of brain cells. Now, how are these cells being lost? This is normal brain tissue, a microscopic view, and you can see here in Alzheimer's tissue there's development of some unusual, abnormal structures that I'm going to show you. And so the first structure I'm going to point out is a senile plaque, and these are these spherical shaped clumps, a little bit like a Brillo pad, of an abnormal protein called beta amyloid. And this is just an illustration of how this beta amyloid clumps around the branches of the cells and then destroys the cells. Now the second hallmark feature of Alzheimer's disease are what we call neurofibrillary tangles. And unlike the plaques, which form outside the cells, the tangles form inside the cells. And there are these flame-like projections that are also involved in destruction of the neurons or the brain cells.
So eventually, these pathological features, the neurofibrillary tangles and the senile plaques with the beta amyloid, they become so prevalent in the brain that you start to see symptoms, you start to see behavioral changes and changes in memory. And this is the stage we've been referring to as mild cognitive impairment. So now the individual has gone from the preclinical phase, where no symptoms were present, to the MCI phase, where symptoms become evident to other people as well as the individual. The impairment in MCI can affect memory, it can affect other cognitive abilities, but the person is still able to function relatively well in their day-to-day life. And MCI has a great deal of heterogeneity in terms of the symptoms. Some people can only just come in with a memory problem. Everything else is fine in terms of their visual spatial functioning, language, reasoning. Others come in where you might have memory plus one or more other areas of cognition affected. And some patients come in where they have other areas outside of memory affected. So there's differences in the symptom presentation of MCI. There's also differences in the course. Many MCI patients will progress, get worse over time, and go into a dementia. Some might stay the same. And we have some patients at our clinic with MCI who've stayed the same probably for at least 8 or 9 years. They're still forgetful, but they haven't really gotten worse. And there's a small percentage, maybe as much as 20%, who get better. Or they might flip back and forth, going from MCI to normal, then back to MCI, then back to normal. These are sometimes called flippers. Not a very positive term.
So Malcolm was saying, MCI, if you're diagnosed with MCI, that greatly increases your risk of developing Alzheimer's disease or another dementia. And so you can see here on the right side of this slide, and again, this study was over 4 years. If you started out healthy, only about 2% of healthy individuals transition to Alzheimer's disease per year. But if you started out with MCI at your initial examination, across those 4 years, 12% converted or transitioned to to Alzheimer's disease every year. And there are studies that have been done for even longer periods of time that show that 7 or 8 years out, 80% of people with MCI develop Alzheimer's disease. So this greatly increases your risk.
So I just mentioned about the heterogeneity in MCI, and typically we break MCI down into 3 major types. There's one type that only have a memory problem. These are called single domain amnestic. And this is just where there's a memory problem. There's a amnestic multiple domain type, and this is where there's memory plus at least 1 or more other cognitive deficits. So they could come in with a memory problem, but also word finding, language problems. Or they could come in with a memory and also have problems with their judgment, or they're getting lost. And then the other type is the non-amnestic, either single or multiple domain type, where they don't have a memory problem, but they have deficits in some other form of cognition. Those individuals who have the memory type, the most likely cause of their difficulty, if you haven't ruled out other possible treatable causes, is probably going to be Alzheimer's disease. The non-memory type, they could have a variety of other causes. So for example, if it's a person who's having problems with their language or their judgment, they might go on to develop a form of frontal temporal dementia. Or if they come in with only a visual spatial problem, where they're getting lost in familiar environments, or having trouble perceiving depth, or going up and down stairs because they can't distinguish where the stair ends, they might go on to develop into Lewy body dementia. So the memory form is the most common form, and typically that will go into Alzheimer's disease.
So let's try to make this a little bit more real with a couple of examples in terms of what do people look like if they're normal, have MCI, or have Alzheimer's disease. So there's 4 examples here. We'll just do a couple. A very common thing that we all experience is blanking on someone's name. But typically that'll come back to you after a few minutes. And so it just takes you a little bit longer to recall it. Well, in MCI, the person is frequently forgetting people's names. So part of it is frequency. This is happening on a regular, routine basis. And in Alzheimer's disease, though, the person eventually doesn't even remember knowing you, doesn't know your name, doesn't even know you, know that you're an important person in their lives. So the last example there is about wayfinding or getting lost. So yeah, we all get a little turned around when we're driving. I do it on a regular basis, so Malcolm might wonder if I have MCI, but you know, we're able to right ourselves. We might be able to use a landmark or immediately say, oh, I should have turned left here when you turned right. Well, a person with MCI is going to become more easily disoriented and have trouble righting themselves. So they may have trouble using a map, figuring out what mistake that they made. Whereas the person with Alzheimer's disease is going to get very disoriented, going to become lost for extended periods of time, eventually also become disoriented not just to place where they are, but also to who they are and to what time it is of day. So you can see the kind of degrees that occur across these three, normal, MCI, and AD.
So this slide shows the prevalence of MCI. And just as we mentioned about how as we all get older, the risk for Alzheimer's disease increases rather dramatically, doubling every 5 years, well, you see pretty much the same pattern with mild cognitive impairment, where the older you get, the greater the risk of having this disorder. So we've been talking about mild cognitive impairment and how heterogeneous it is in terms of the course and the symptoms and the etiology. Many patients will progress into dementia, and as we mentioned early in the lecture, dementia can be distinguished from mild cognitive impairment in that in the dementia, now the person is not able to function in terms of their everyday living skills. They're having difficulty shopping, driving, paying their bills, and someone has to take those over. So the distinction between mild cognitive impairment and dementia is the presence of these functional deficits. Let's just take an example, taking a person who goes from normal aging through these three different stages, just to make it a little more concrete. So let's take as an example a salesman at a car distributor. And in his normal best times, when he's normal, he can remember the name of his top 30 or 40 buyers who come in and buy a fleet of cars. And he knows their names, he knows where they went to school, what their favorite sports are, their wives, their children's names. So he's got that all just at the tip of his fingers. He can rattle it off very quickly. Now he's sort of slipping into the pre-clinical stage. He's still able to function very well in his job, but he's realizing that his memory for this information is much more fuzzy. Now he's having to take little notes, keep them in a notepad, so when his secretary calls him and says, Mr. Smith is here, he needs to consult his little notebook and figure out who the wife's name and where he went to school and what cars he purchased last time. He's still able to function at his job, but he's experiencing some problems. He goes to his doctor. The doctor says, well, you're fine. I don't know what you're worried about. It's just stress. Now he goes along and he starts to progress into mild cognitive impairment. Now the memory problems are becoming evident to his coworkers. He's forgetting appointments. He's filling out purchase slips, but he's leaving out information. His boss is aware of his problem. Maybe his coworkers are starting to compensate for him. And he goes to a clinic or a doctor, and yes, he does have problems on objective tests. And his family's seen it, and they've encouraged him to go to talk with the doctor. He's still able to go out shopping after work. He can still make purchases at the store. He can still find his way around driving. But now he's definitely having problems, and there's more than him concerned about it. And then if he slips into the dementia stage, now he's no longer able to work. He comes to work disheveled, unshaven. He's not eating well. He's getting lost driving to work. And he's really no longer able to function, and so he takes early retirement. So that sort of shows this very gradual process, and that preclinical phase and the stage even before that when changes are starting to occur, this whole process could be a very long phase. We know from research that the MCI phase can last anywhere from 3 to 8 years, and the dementia phase on average from about 5 to 8 years. And then if you add in maybe a decade in the preclinical phase, you can see how very long and drawn out this whole process is.
So remember I said earlier that the term dementia is like an umbrella term, that there can be many causes of dementia. Alzheimer's is the most common. So this slide illustrates that concept and shows you the three major types of dementias. And we'll start over here on my right with the reversible dementias. This is a dementia, or what looks like a dementia, that it can actually be treated and resolved. Only about 5 to 10% of all cases of dementia are reversible. And here's some things that could cause a reversible dementia. Things like depression, medication side effects, and infection. What do you think the most common cause is of a dementia that you can reverse or treat? What? Yeah, we got a few depressions and we got a few medications. It's actually medication side effects. There are so many medications that older adults take that have as a side effect concentration difficulties, difficulties with thinking. This is one of the things we always want to look at first, is if there's been a medication change. Now, the second type of dementia is non-progressive. So a good example of this is someone who has a traumatic head injury. Perhaps they're in a major automobile accident and they have a severe injury to their head, and as a result, they have some changes in cognition. But it's non-progressive. It stays stable over the course of time. And then the third type is progressive. And this counts for 85% or more of all dementias. And as I said, Alzheimer's disease is the most common cause of dementia. Now we're going to be talking about a couple of other common causes of dementia this evening. Specifically, we'll be talking about dementia with Lewy bodies and frontotemporal dementias. Dementia can also be caused by vascular changes in the brain, by Parkinson's disease, and other less common conditions, so like Creutzfeldt-Jakob disease or mad cow disease.
Just if you go back, these progressive and non-progressive, they don't necessarily cause a dementia, but they do cause cognitive impairment. And that's one of the things that the doctors would be ruling out in a thorough examination. So, for example, under the non-progressive, you have sleep apnea. And so people who have sleep apnea, they can have problems with their thinking, their memory, their attention. And if you treat it appropriately, then you can see some improvement. So those could be cognitive impairment, not necessarily a dementia.
What's really important to recognize is there are a lot of medical conditions that can cause symptoms of dementia, can create problems with memory and thinking abilities. And you can see here some of the most common medical conditions that can affect one's thinking. Malcolm already mentioned sleep apnea, but here's some others related to coronary artery disease, respiratory and kidney diseases, even obesity, and also diabetes, and the prevalence at which they cause cognitive impairment. So you can see sleep apnea is high on the list after age 60, as well as diabetes and hypertension.
The most common cause of dementia, as Cordula mentioned early on, is Alzheimer's disease. And so if you put everybody over the age of 65 who has dementia into this pie, what you'd find is that over half of them, 55%, have dementia solely due to Alzheimer's. About 20% have dementia due to Lewy body disease, which we'll talk about, and about an equal proportion or so have it due to stroke or vascular disease, meaning poor blood flow in the brain or mini strokes or large multiple strokes. There's a smaller percentage who might have dementia due to other causes like traumatic brain injury and frontotemporal dementia. What's interesting is that within these two groups particularly, the Lewy body and the vascular, when you follow these individuals and they pass away and you actually do an autopsy of the brain, what you find is that the majority of them also have Alzheimer's disease. So about half of the Lewy body patients, maybe even more, have not only Lewy bodies in their brain, but they also have the Alzheimer's neurofibrillary tangles and plaques. And they have this, what's called Lewy body variant of Alzheimer's. And about the same thing is true when you look at the vascular dementia patients. So in a living patient, the clinician might diagnose them as having vascular dementia, dementia due to multiple strokes. But when you look at their brain at autopsy, the vast majority of them will also show signs of Alzheimer's disease. So when you add that 50%, 55% plus half of these and half of these, you can see that Alzheimer's is probably either the major or a contributing factor for about 70% or more of all dementia.
So has anybody ever seen these pictures of these people before? Yeah, who are they? Yeah, Dr. Alzheimer and his patient, Dr. Alois Alzheimer. Yeah, and he does look a little bit like Teddy Roosevelt, that's right, people say that. Dr. Alois Alzheimer, a German neuropsychiatrist, and his patient, Augusta Dieter. And Augusta was the first patient in which Alzheimer identified these sticky plaques and fibrous tangles in her brain upon death. She was brought to Dr. Alzheimer by her husband, Carl, because she was having some very unusual symptoms. She was having difficulty with memory and thinking, but she was also having some changes in behavior and personality. So she was starting to accuse Carl of going out with other women, being unfaithful. She was packing mail away under her bed. She was wandering around, and she could no longer do what was expected of her as a wife in terms of keeping up the household at the turn of the century. And so Dr. Alzheimer followed her for about 5 years, and upon her death did an autopsy of the brain. And as I said, he found those clumps, those plaques, those sticky clumps, and also the tangles. And the disease was subsequently named after Dr. Alzheimer's. Because Augusta D was so young, she was 51 when she was brought to Dr. Alzheimer. For a long time it was thought that Alzheimer's disease was a rare form of a pre-senile dementia. So very rare, occurred in people under age 65. Well, much later, decades later, in the 1970s, researchers in Britain, Blessed Tomlinson and Roth, actually realized that Alzheimer's disease is the most common cause of dementia. They did autopsies on about 50 people who had been diagnosed with arteriosclerosis and found that the vast majority of them had these plaques and tangles that were causing their symptoms of memory and thinking difficulties. So we want to talk a little bit about warning signs. These are the 10 common warning signs of Alzheimer's disease as published by the Alzheimer's Association, and things that we ought to be thinking about and looking for.
And probably the most common symptom and the first and most prevalent symptom is the memory loss. And we've already talked about how the memory loss gets progressively worse over time. There are a small number of Alzheimer's patients, maybe a quarter, who don't initially come in with the memory loss. They may have deficits in other areas like language or visual spatial skills, but eventually, over time, memory and these other things will all kick in together. So memory loss is the first and most dominant symptom.
So another thing that we want to watch for early is having some challenges in planning or problem solving. So there's some good examples of that on the slide, including following a recipe and if the person is a cook, also being able to complete a meal so that everything's done on time. It takes a lot of coordination, or difficulty with finances and managing accounts and the tracking of bills and the tracking of a checkbook. Also, many individuals with Alzheimer's disease have told me that doing even simple things takes a lot of effort now. Something that came easily before takes a lot of focused attention and effort. Having difficulty with tasks at home, so again, there's some great examples there. It might be managing a remote control or managing a budget, having difficulty using the microwave, or playing a familiar game. These are the kinds of things you might see early on.
Other symptoms that are seen early on are difficulty with orientation to time and place. And the patient loses the ability to judge time. So, for example, it's not unusual, family members will say, you know, I told my husband that I was just going out to the store, and I was only gone 15 minutes, and I came back and he accused me of going out partying because he said I'd been gone for hours and hours. And so patient loses a sense of time. They often can't tell you what year it is, what day of the week it is, the month. They also have difficulty with understanding visual spatial relationships. So they have difficulty judging like the speed of an oncoming car. Later in the disease, they might get lost driving to very familiar environments. So they've gone to the same grocery store for 20 years, but now they're getting confused about where they need to turn. And particularly if they're faced with a detour. So they always go this route, there's a detour because of construction, now they have to go an alternate route, and they get totally lost and they end up in San Diego hours later. Problems with language are also very common. Probably the most common one that also occurs in normal aging is word finding and naming, where you get stuck and you can't think of the word that you want to say. Well, that's true for Alzheimer's patients, but it becomes very prevalent, very noticeable. They may get stuck in the middle of a conversation because they can't find the word and then they forget what they were going to say, or they would be repeating themselves. They also will be misplacing things, difficulty finding their way around. So if they lost something on their way here, they would have difficulty retracing their steps, which way they came in.
Another thing that we want to watch for is changes in ability to make good judgments. So people with Alzheimer's disease, and even in the very early stages, may be susceptible to scams. They may be more vulnerable to be taken advantage of because their reasoning abilities are impacted. Also, we see the person often becomes more apathetic or withdrawn. We might see some personality changes. So as they have more difficulty doing things like a favorite hobby, the example on the slide, they stop doing it. As they have more difficulty in social interaction or relationships, they may withdraw from those. It becomes harder for the person to take initiative. And finally, we can see more personality changes. Malcolm said that memory is often the first change, but there have been studies done that have shown that personality changes can sometimes precede the memory changes. So here's a good example. I knew a caregiver who told me once that the very first change, looking back, that she experienced was a change in how her husband made love to her. Now, she thought he was depressed at the time, but actually he was becoming less appreciative of her. He was becoming more egotistical in the way he related to her, and over the course of time they realized that he had a dementia as other symptoms started to emerge. Also, very importantly, the slide illustrates how the person can become upset outside of a familiar environment where they feel safe. So let me see, we were, it's 6 o'clock. Boy, we did perfect. This is where we were going to give you a break, and we did it in an hour. We thought that you all might appreciate a real quick stretch break now. All right, well, we're going to get back. Actually, a couple of people during the break asked me about how do we diagnose someone with dementia, or they were taking their loved one into a neurologist because of some difficulties, and so that's exactly what we're going to talk about now. What does it take to do a thorough diagnosis of a memory problem?
And unfortunately, when you look at the research, primary care doctors and emergency room doctors, they are not very good at identifying dementia in patients. The literature suggests that about 7 out of 10 patients with mild to moderate dementia are not being identified by their primary care doctor, and about 9 out of 10 patients with mild cognitive impairment or very mild dementia are being missed. And some of that is obviously not due to the doctor's fault. If they have a very limited amount of time, only 7 to 11 minutes typically to assess the patient, you aren't going to be able to identify a dementia in that short span of time. It may also be that the doctor doesn't feel comfortable, maybe doesn't have the training to identify a dementia and doesn't want to make a misdiagnosis. But there's many reasons, time, cost, that ultimately lead to many patients not being diagnosed early.
Now, there are a lot of misconceptions. Remember at the beginning of the lecture I said how 62% of Americans don't know a lot about Alzheimer's disease? And so as a result of that, there's a lot of misconceptions. And one of the most common ones across all cultures is, oh, you're just getting old. People do it to themselves, they do it to their family members, and doctors do it as well. Oh, that's a normal part of aging, just getting old. Well, as you can understand from today's lecture, when you're having cognitive problems, it's not just a normal part of aging. But there's some other things that we see, especially in a place like California where there are a lot of minority populations. We see that in Asian cultures often the signs of dementia are thought of as going crazy or having a mental illness or karma, perhaps. You know, it's your fate. Sometimes it's believed to be a result of something that you've done wrong. It's even in, I was preparing for another presentation, and even in the common Christian tradition, there's this idea that disease is somehow due to sin. So somehow you've done something wrong.
That's the next slide.
Oh, sorry. Okay, how about I turn, yes, well, you've got on your paper, right? So he had his memory lapse earlier, so I get mine now. At any rate, it could be due to stress or these are the common misconceptions that get in the way of an accurate diagnosis. And this causes a lot of unnecessary stress. There have been some studies that have looked at how long it takes to get a diagnosis. And in one survey done by the Alzheimer's Foundation of America, they found that getting an accurate diagnosis took, on average, over 2 years. And the family saw 2 or more doctors trying to get that diagnosis. So they had to pursue this. And when there's not an accurate diagnosis, there can be a battle over what's wrong with the person. And a lot of stress related to that, so that the diagnosis can provide relief and understanding. The person's not going crazy. They're not doing this on purpose, that there's an actual disease that's causing these changes. And then the person can take advantage of treatments and of education. So there are a lot of missed opportunities when we don't diagnose early. The medications that we have today that we're going to talk a lot more about in June are actually most effective when we start them early. So if we can miss that window of opportunity. Also, the earlier you start coming to lectures like this, going to a support group, engaging with the Alzheimer's Association or some of our other community partners here today, the better you're going to be able to cope over the long haul and plan for the future. And very importantly, we have to pay attention to safety in this disease. That as a person progresses, the cognitive decline progresses, there's a risk to driving, there's a risk to doing maybe a favorite hobby like woodworking. So we need to pay attention to those and take care of those things.
Well, how do we do the diagnosis, and what is the purpose of the diagnosis? Well, essentially when a medical team, like a neurologist, a neuropsychologist, a nurse practitioner, maybe social worker, they get together and they go over the data from a patient's evaluation. What they're essentially trying to do is to place the individual in a category. Is this a normal aging changes? Is it someone who's in this questionable phase where they're noticing a problem yet they're still normal? Or are they MCI? Or are they dementia? And if they have a dementia, what type is it? And what stage of the dementia is it? Also, you want to identify any comorbid conditions that could be worsening cognitive problems. So, for example, is the person not only got mild cognitive impairment, but are they depressed? And is that depression worsening their attention, their memory, their word finding? Do they have a thyroid deficiency? Do they have a vitamin B12 deficiency? Is there an infection present? All of these comorbid processes could be worsening cognition, and that's one of the goals of a complete workup.
So basically, this next slide, Malcolm has really already summarized it. When you're doing a diagnosis, you want to look at all these other possible causes. I think one he didn't mention is sensory impairment. So if the person's having vision loss or hearing loss, they may look demented. So again, the process is to identify any possible cause of the cognitive problems and to treat what's treatable. Key components of a dementia evaluation are listed on this slide. So very important is getting a clinical history, a thorough clinical history, looking at factors such as whether the person ever had head trauma, whether they have had a history of alcohol or drug abuse, whether they have cardiovascular disease or other diseases that may affect their cognition. We want to do thorough physical and neurological exams to check their overall health, to look for symptoms of other conditions. So perhaps some weakness on one side that would indicate a stroke, or perhaps some difficulty with movement that might suggest Parkinson's disease. We look for these kinds of things in physical and neurological exams. Neuroimaging, so we're going to take pictures of your brain. So magnetic resonance images, MRIs, or perhaps PET scans to look at metabolism and blood flow in the brain. We need to do labs, so we're going to look for things like vitamin B12 deficiency to rule out those possible contributors, as well as a thorough neuropsychological assessment, a battery of cognitive tests that looks at how you are functioning, how's your memory, how's your language, are you able to reason well, and so forth.
So really in a comprehensive diagnostic workup, there isn't one single test that you can do that you can use to diagnose dementia. And that's a misconception that we often see, where families will come in and they'll say, oh, but my husband, he had a normal MRI, so he couldn't have dementia. Well, probably at our clinic, about a third of the mild patients with Alzheimer's who we diagnose as having Alzheimer's, they have a, quote, normal or unremarkable MRI. So you can't just rely on one single test. There is no blood test for Alzheimer's disease, at least at this point in time. So it's really putting all of these parts of the puzzle together: the cognitive testing, the imaging, the labs, the medical history, how the disease started. All of it has to go together before you can really start to see the big picture and come up with an accurate diagnosis. And it's not surprising that a primary care physician who doesn't have all of these tests done, maybe their accuracy is going to be much less than a specialty clinic where we can do all of these different kinds of assessments.
So I just mentioned cognitive testing, and you can see here's an example of one test that is looking at your visual spatial abilities, and so it's asking you to put those puzzle blocks together in a way that it replicates the image on the card. So there are many different kinds of cognitive tests we do at our memory clinic, and they test various cognitive abilities here, as I was mentioning earlier: memory, attention, language, perception, reasoning, judgment, orientation to time and place and person. And we also do imaging, and you can see Malcolm here showing the results of some imaging to a caregiver. Now, these particular drawings, now in this case, remember we showed you a side view of the brain before. This time we're looking at a brain from an MRI where they're taking pictures of your brain like you're slicing a loaf of bread back across your head. And you can see here in the mild stages, we talked earlier about the hippocampus, that important structure for learning and memory. And remember these folds, look at how nice and tight they are. This is very early on. Then by the time we hit the moderate stages, you can see that there's been atrophy or shrinkage in the brain, in the hippocampus here, and also in the ventricles, which are passageways for cerebrospinal fluid. And by the severe stages of the disease, these changes have become dramatic. You know, the hippocampus is shrunk so much, and here all over, as well as the continued widening of the ventricles. So basically what's happening is cells are dying, and this is all fluid where there was once healthy brain tissue. Go ahead.
And this is just from an autopsy showing a comparison of a normal brain. This is the hippocampus, and this is part of the temporal lobe involved in language and memory. And this is an Alzheimer's brain of a person the same age but who died in the advanced stages. And you can see the noticeable atrophy and overall volume loss in the brain.
So
Then-
this, oh, go ahead. Was there more?
No.
No, this one, this again shows you the same. It's the same type of image where they're going across, and you can see the changes again from basically normal here in the hippocampus to mild. You're starting to see some atrophy here, and then moderate atrophy. You can see more shrinkage here in that area, more empty black space, and here severe atrophy. So this again is from an actual individual's autopsy.
So typically in a standard workup, the choice would be some kind of structural scan, like a CAT scan or an MRI. But sometimes doctors may want to choose a metabolic scan, like a PET scan or a SPECT scan. And these are images of a SPECT scan. And a SPECT scan is essentially looking at blood flow in the brain. And these top images are views from the side. So you're looking at this person facing to the side. So this would be, in a normal adult, this is the frontal lobes, and this is the parietal lobe at the back, and then the temporal lobes and the brain stem down here. And in a SPECT scan, it's looking at blood flow, and so in the middle of the brain we have these cavities filled with fluid, the ventricles, so there's no blood flow. But good blood flow is shown by the red and the white color, and you can see a nice uniform pattern of blood flow in our normal adult. And this is looking as if you're standing above the person looking straight down, so their nose would be out here, their ears along the sides. And you can see again, very good blood flow. This is in Alzheimer's disease, probably in the middle stages. You see a reduction in blood flow shown by the yellow, which is about a 50% reduction in blood flow compared to the red. You can see it in both the temporal lobes and also into the parietal lobes, which would be involved in language and some of our visual spatial skills. And this is a side view showing the atrophy in the temporal and the parietal areas. As I said, this is about what you would see in a middle stage disease. Early in the disease, it may be very difficult to separate the brain on a SPECT scan from that of a normal adult.
Done? All right. Well, when we give you a diagnosis of Alzheimer's disease, we give that to you by level of certainty. So you may receive a diagnosis of probable Alzheimer's disease, possible Alzheimer's disease, and it's only after death that we can make a definitive diagnosis. So I just wanted to explain what these terms mean. Basically, we've talked about the characteristics of dementia. Probable Alzheimer's disease means that through the diagnostic process, the doctors have eliminated all other possible causes. There's no other contributing factors. The only possible cause of the person's cognitive impairment is Alzheimer's disease. So we call that probable Alzheimer's disease. It's a higher level of certainty than possible Alzheimer's disease. Possible Alzheimer's disease is when there may be another contributing factor that's present. So the person may have vascular disease. So we think that the vascular disease is contributing, but we also think Alzheimer's disease is contributing. So we're not quite sure, because there's a second problem that may be contributing to the disease, or to the cognitive difficulties, excuse me. And then thirdly, there's definite Alzheimer's disease. And I mentioned that diagnosis can only be done at autopsy, when we actually go in and look at the brain and we look for those plaques and tangles and changes we've been discussing this evening.
Well, one of the really major accomplishments in the last few years is the development of possible biomarkers that could help increase the certainty about the diagnosis of Alzheimer's, particularly early on. And there's a number of techniques that have been developed. One is to look at the levels of amyloid, beta amyloid and tau, the protein that's involved in the tangles in the spinal fluid. So one test is to draw some spinal fluid, because the spinal fluid circulates throughout the brain, and it's essentially replaced. The total amount of spinal fluid is replaced about 3 times every day, but as it's circulating, it might take some of that amyloid into the spinal fluid, and you can assess the level by doing a lumbar puncture. Another test is to do some what are called amyloid imaging tests, and these are relatively new. What the amyloid is, again, it's sort of the building blocks of these plaques, and before you could only measure or look at the amyloid at autopsy. But in the last 10 years, they've developed first something called a Pittsburgh Compound B, or PIB scan, which is where you can look in a living individual, scan their brain, and actually detect levels of amyloid. And just recently, the FDA approved a particular type of a scan called a AMVID scan. And this is looking at these amyloid deposits. This is a normal scan, a normal adult, and the amyloid shows up as these bright red areas. And so in a normal adult, this is just different perspectives of the brain, a side view, a view looking from the top down, and a view looking, slicing like a loaf of bread front to back. But you can see very little evidence of amyloid compared to an Alzheimer's brain, where you can see an accumulation in many parts of the brain.
So maybe you should explain, this is a special, what they call tracer, so that before you go in for your imaging, they inject you with this tracer, and the Amyvid actually sticks to the plaques. And that's why we can see in the images there, the areas where there are actually these beta amyloid deposits or plaques. And these, as Malcolm said, are new compounds that allow us for the first time to actually see the presence of the plaques while the person's living.
Well, ideally, this is what you would hope to see. So the amyloid deposits would be these brighter red colors. And this is a scan of an Alzheimer's patient where we're seeing some amyloid deposits. This is an MCI patient where we would normally expect to see less amyloid. And this is a normal adult where we're not really seeing any. And so this is sort of the idealized situation that you would hope to see. But unfortunately, that's not what actually happens. This is sort of more the realistic view, where you can have some normal adults who have no amyloid deposition. But you can have other normal adults, people who are functioning quite well, who are showing amyloid deposits in the brain. And this normal adult who has a high PIP scan or high levels of amyloid sort of actually looks worse than the MCI patient who has relatively little. And there's not much difference between this Alzheimer's patient and this normal who has a high concentrations. So unfortunately, it's not this idealized situation where a normal will show absolutely no amyloid and an MCI will be middle stage and then an Alzheimer's will have abundance of amyloid. You can have amyloid present even in a normal adult. Now the question is, if you followed that normal adult for 10 years, would they then develop into Alzheimer's disease? And that's sort of an unanswered question. We don't know the answer to that. But right now, this is a normal adult who's functioning quite well, no problems. So the percentage of normal adults who show a positive amyloid accumulation is anywhere from about 1/3 to 1/4. MCI, you're going to see more of it, and Alzheimer's, most patients will show a large accumulation of amyloid. So the conclusion is you couldn't just say, whoa, doctor, give me an AMVID scan, and the doctor comes back and says, oh, you've got some amyloid deposits, and you say, oh my goodness, I've got Alzheimer's. Well, that doesn't necessarily have to be true because 1/4 to 1/3 of normal adults can have amyloid on the scan. So just recently, with the AMVID scan being released, there was some guidelines published, in fact, just about a month or so ago in this journal. And just to give you some ideas on the appropriate use of a scan, and those are marked here, but the appropriate use is that, first of all, you need to have a full diagnosis. So you can't just go into the doctor and say, give me an AMVID scan. You need to actually have a full diagnostic workup where you have to objectively confirm the presence of a cognitive impairment. So also the AMVID scan needs to be ordered by a specialist. So a general practitioner who's not familiar with diagnosing Alzheimer's really should make a referral to someone who is, and then if they feel it's warranted, then you could get the scan. The diagnosis, the imaging can help to increase our certainty about the diagnosis of whether Alzheimer's is present or not. So let's go back and just take, say, an MCI patient who's been MCI for the last 5 or 6 years, and we know that they're maybe at risk of developing Alzheimer's disease, but they haven't really changed. Maybe in that situation, I might recommend that kind of a scan to say, well, is it due to accumulation of amyloid and maybe it's likely to develop into Alzheimer's, or is it due to some other cause, like vascular problems? There's inappropriate use of the scan, and there's a couple of points here. So first of all, you have to have patients meeting criteria for Alzheimer's disease or mild cognitive impairment before you order it. You can't be sort of what some people call the worried well, who are patients who maybe their mother had Alzheimer's disease in their 90s and they're worried that they're going to get it, so they want to go get a scan. That would not be an appropriate use. So the person must have cognitive impairment. They must be seen by a specialist who has diagnosed some kind of a cognitive impairment, and the value of the scan would increase our certainty of the disease or maybe alter the treatment plan. Okay.
All right.
So these are just some of the potential biomarkers we have. Again, we're really trying to see these plaques and tangles, or the tau abnormalities. And we now have the AMVID and the PIP scans. Other biomarkers that are standardly used are like the SPECT or the PET scan. And we also can have some biomarkers really coming from our structural imaging, like the hippocampal atrophy on an MRI. So although the CSF, spinal fluid, and the AMVID scans are the most sort of high-tech recent additions, there's these other biomarkers that have been used for a period of time.
So this next slide really helps you to understand why this is so important. So down here on the horizontal axis, you can see there's a progression from normal to MCI to dementia. So this is the progression. And these are various markers of the problem of the cognitive impairment. And you can see here that the first clinical signs, so clinical symptoms in the green, start way out here, start way out in MCI. The same thing with memories, like the cognitive testing we were showing you, that starts way out here also in just in MCI. But A beta, the amyloid accumulation, starts many years before. It starts when we're, quote, normal, as we've been saying. So these importance about biomarkers is that if we were able to identify effective biomarkers, we might be able to identify the disease in someone who, quote, looks normal, but already has the disease, and perhaps we could treat it there. It's much like we don't treat diabetes once the person has gone blind from the diabetes. We treat that person way back when we first pick up blood sugar abnormalities. So these current ways of diagnosing the disease identify it late in the process. One of the reasons we believe our treatments aren't that effective is because we're giving them so late in the process. So we need to find better ways to diagnose earlier and then build early interventions. So this slide basically is a model for showing you that we're moving leftward with the diagnosis. We're moving to earlier and earlier stages where, as I said, our goal here is to be able to identify someone when they have no outward symptoms. There's no reason that you would think, speaking to me or looking at my functioning, that I have a cognitive problem. But we want to be able to pick up this evidence that there is an accumulation of amyloid, either in the cerebral spinal fluid, in blood, or in imaging, and be able to do that with a high level of accuracy so we can treat people early.
Just to give you an idea, when the Alzheimer's Clinic at UC Mind was started in 1989, and the majority of patients that I would see there with our neurologist, they would probably be in the mild to moderate stages of Alzheimer's disease. So patients were coming into the clinic for their initial evaluation when they were sort of way out here in the mild to moderate stages. Over the last 25 plus years, now the majority of patients that we see are probably coming in somewhere in this mild cognitive impairment stage. And probably 10 years from now, we might be able to identify patients even earlier than the MCI in this pre-symptomatic stage. So the diagnosis is moving earlier and earlier into the disease, where hopefully if we have better medications and treatments, they'll actually be able to make a difference in terms of the disease progression.
Right, either to slow the disease progression or perhaps even to get to the point where we can prevent the disease, so stop the disease in its course. So now we want to spend the next few minutes speaking about two other forms of dementia. We have about 20 minutes left. First, we want to talk about dementia with Lewy bodies, which was identified by Dr. Friedrich Lewy in 1912. And the characteristic markers of Lewy bodies, the characteristic marker of this disease are what we call Lewy bodies, the large pink areas which have a central core and a halo around them, and they're found in the deeper areas of the brain in what we call the substantia nigra.
Yeah, these are seen in Parkinson's disease, but in Lewy body disease, you not only see them in the area deep in the brain affected by Parkinson's, but also you see them throughout the cortex, or the thinking parts of the brain. And just some of the facts about Lewy body. As we showed in that pie diagram earlier, Lewy body is probably the second or third most common cause of dementia after Alzheimer's. It seems to affect males more than women. About 2/3 of patients tend to be males. The average life expectancy is a little shorter than that for Alzheimer's disease. It's possibly because many of them have these motor problems that you see in Parkinson's disease as well as the cognitive, so you've really got more areas affected. It's frequently misdiagnosed, particularly in the early stages, as some other kind of motor disorder like Parkinson's. Lewy body and Parkinson's share many similar features, but in Lewy body dementia, typically the dementia, the cognitive changes, and the Parkinson's symptoms you see in Lewy body are more rigidity and stiffness. The resting tremor you get in Parkinson's isn't really very common in Lewy body. Maybe 1 out of 10 Lewy body patients shows it. So in Lewy body, the Parkinsonian symptoms, the motor changes, and the cognitive changes, they occur very close in time. Now, Parkinson's patients, they can also develop into a dementia, but the dementia occurs very late after they've had Parkinson's disease for many, many years. And some, not all of them, might also then later develop a dementia. So it has some similar features to Parkinson's, and that, I think, leads to some of the misdiagnosis. The major symptoms that we look for in Lewy body, there's really 3 of them. One is called fluctuating cognition. The other are well-formed and highly detailed visual hallucinations. And then the third one are these Parkinsonian features of rigidity and stiffness and slowness of movement. Let's look at a couple of these, looking at the fluctuations first. These are probably present in about 80 to 90% of Lewy body patients. And they're often very difficult for families to describe. And typically what they'll talk about is how the person has lapses of attention and concentration, where it's like you're talking to the person and they sort of zone out on you, where the family will say, you know, he's looking right at me, but it's not really as if they're seeing me. And then they sort of come back and, oh, what were you talking about? And so they sort of have these zoning in and out. They may also be sleeping excessively during the daytime, yet getting adequate rest at night. They can also have inconsistent performance in their everyday activities. So sometimes families will say to me, you know, my husband, I use the word husband all the time. It's not that we're the weaker group necessarily, but the husband, you know, the
You're
wife will say.
You're opening yourself up now.
Yeah, They'll say, like, my husband sometimes, you know, he can work the microwave fine, but other times he's very confused and he can't operate it. And then if I wait an hour, he's back using it appropriately. Or with the remote control, you know, that sometimes he's working it fine, he can change the channels and do everything appropriately, but then he'll get very confused and won't know how to work it. Give him time, he'll be back using it appropriately. So you have these marked fluctuations in cognition and awareness that occur in Lewy body, and you don't necessarily see those kinds of things in Alzheimer's disease.
Another core feature of dementia with Lewy bodies is vivid, detailed visual hallucinations very early in the disease. Now, you might see hallucinations in Alzheimer's disease, but that would be when the person's much more advanced. And so you can see that these are very vivid, and they usually involve people, animals, and insects. And so they're non-threatening, and the person's often aware that they're hallucinating. So I wanted to read you just one comment from someone with dementia with Lewy bodies who told me this. I once saw a troop of cavalry on the greenbelt behind their home in such detail. Where did all the detail come from? There they are with their lances and horses. In your heart of hearts, you know there is no troop of cavalry, but there is part of you that says there is a troop of cavalry. So we would see these troops, and he would also see gangs of people. And this is a gentleman who has these hallucinations on a regular, recurring basis, to the extent that he doesn't even feel safe in his own home because he always feels like he's under siege because of these hallucinations.
We had a gentleman who we diagnosed with Lewy body, and he was actually still working. He was taking the Amtrak from Orange County down to La Jolla, and one day he came to his wife and he said, "Oh, I'm really loving the train trips because now they've got a jazz band playing." And the wife was surprised, and he said, "Oh yeah, they're all there. They're in their sort of Dukes of Dixieland straw hats with striped shirts, and they're playing, and I really enjoy the music." And so she decided to go on the train trip with them one day, and he was saying, "Oh, isn't the band great?" And there was no band. But he was seeing and he was hearing this music. I had another patient, one of the first ones, who told me about a family of, he thought they were Amish individuals who would come into the bedroom at nighttime, and they would have a saw and they would cut a hole in the closet door, and then this family would take his clothes on hangers and pass them from one member of the family to the other. And he could describe what they were wearing. There was like a grandfather, a grandmother, mother, father, and children. And he wasn't upset by it. He sort of realized that this is a hallucination, but these were individuals, both the one who had the band playing on the Amtrak and the one with the Amish family. They were very high functioning. They were not severely demented. And these early onset of visual hallucinations could also have auditory components to it, are something you see quite regularly in Lewy body dementia, and that helps to distinguish it from Alzheimer's. Other features of Lewy body are shown on the slide. One of them is repeated falls, unexplained falling. They show a marked sensitivity to certain types of drugs, and that's one of the precautions you tell families, that some of the antipsychotic drugs can be very dangerous to use with a Lewy body patient unless they're strictly being monitored. Another feature is what is called REM, or rapid eye movement sleep behavior disorder. And this is something that you see in Lewy body, but also in Parkinson's disease and some other disorders. And it's really where the patient acts out their dreams at night. So normally when we fall asleep, we lose muscle tone. So you can't move your limbs. So that's why you can have dreams like someone is chasing you and you're in lead boots because you can't move your feet. Well, in Lewy body patients, they don't lose their muscle tone, so they can act out their dreams. And so sometimes families will say, you know, my husband is like he's in a fight, he's punching me at night, and yet he's totally asleep, or he's running. We had one gentleman that actually leapt out of the bed when he was asleep, knocked over the lamp and the bedside table, and he was totally asleep because the wife was reading at the time, and he thought he was jumping for a basketball hoop. So this REM sleep behavior is something, if we see it early on in the disease, that would also be sort of a red flag that maybe we're looking at Lewy body dementia. On a SPECT scan or a PET scan, you also might see that the Lewy body patient has better activity or functioning of the temporal lobes, and they may do better on memory tests than a typical Alzheimer's patient. But they may also show reduced activity in the parietal and occipital lobes, which are involved in the visual spatial and visual processing. And this is what these large arrows are pointing to, comparing it to an Alzheimer's patient. And the greater the reduction in activity and blood flow and metabolism in this parietal occipital lobe area, the more likely the patient is going to have visual hallucinations.
Now we're going to talk very briefly about frontotemporal degeneration, and this type of dementia was identified by Dr. Arnold Pick, as you can see, in 1892. In terms of a few facts about frontotemporal dementia, you can see that typically it starts before age 65. So unlike Alzheimer's disease, which typically starts after age 65, actually typical age of onset you can see there is in the 50s. It's the third most common form of dementia after Alzheimer's disease and dementia with Lewy bodies, but the second most common form for people under age 65. In fact, in young age groups, 45 to 64, the prevalence of frontotemporal dementia is the same as that for Alzheimer's disease. So 20% of young onset dementias are due to frontotemporal dementias, but only 5% after age 65. So you can see a brain here.
This is just a brain at autopsy, but this is looking at, this is the back of the brain with the cerebellum here. This is the front of the brain. And you can see how shrunken the frontal lobes are in this FTD patient. The frontal lobes have these very knife-like or very sharp gyri. You can compare like how thin and shriveled but narrow this is to, say, a normal looking part of the brain at the back. So the frontal lobes are involved in judgment, reasoning, planning, organization, multitasking, and you typically have atrophy in the frontal and in the anterior parts of the temporal lobe, which would be involved in memory and some of the language processing.
So this just shows you, we've already talked about plaques and tangles, we've talked about Lewy bodies, and these are the changes that occur in frontal temporal dementia. They're called Pick's bodies after Dr. Pick.
It the imaging in a frontal temporal patient, if you look at just the brain, it has what is called a spongiform appearance because these are sort of bloated cells and you have all of these spaces. So it's like if you took a sponge and you cut it and just opened it and looked at it, that's sort of the type of appearance of the brain in a frontal temporal patient. This is also just looking at a SPECT scan to differentiate it from Alzheimer's, but in frontal temporal dementia, you have the atrophy, the shrinkage, the loss of activity in the frontal and anterior temporal lobes. These are again looking from the brain down, so this is the front, the nose, the ears, along the side and the back. And you can compare this patient who's in the middle stages with frontal temporal dementia to a middle stage Alzheimer's, where we've got the parietal and the temporal lobes affected, and less so in frontal temporal dementia. When we talk about frontal temporal dementia, there's really two types that we talk about. There are the behavioral type, where we're seeing marked changes in their personality and behavior, and then there's a language type. And there's two kinds of language types. One is called semantic dementia, and the other is called progressive non-fluent aphasia.
And I just see that I made the chart wrong, so sorry. The progressive non-fluent aphasia should be under non-fluent, so that's an error, my error.
Just to give you an idea of the different symptoms, however, the next slide.
Oh, excuse me.
Semantic dementia is sometimes referred to as sort of the what is dementia, because what happens in semantic dementia is the patient loses the knowledge about particular words or individual words. So imagine you have a mental dictionary, okay? You've got a Webster's dictionary in your mind. And someone comes along and they just take out a whole definition of a word. So, for example, they go in and they obliterate the word animal. And so you ask a semantic dementia patient, tell me all the animals you can think of in a minute. And this well-educated person looks at you and says, what's an animal? Is this an animal? Maybe, is this an animal? I don't know what an animal is. Can you tell me what it is? So they lose the meaning of concepts. So they not only lose the types of animals, but they lose the specific properties of it. So in a semantic dementia, the patient may have difficulty comprehending what you're saying to them because some of the words you're using, they no longer know what those are. So the patient may not understand instructions, they may have difficulty with naming objects in their environment, but their speech is very fluid. They're able to talk quite normally. That distinguishes it from progressive non-fluent aphasia, where the patient clearly understands what you're saying to them, but they have a very stuttering, hesitant, very difficult time producing speech. So they would have lots of it's called telegraphic speech, where if they're trying to tell you something, they're maybe leaving out the articles and prepositions, just like in a telegraph, you just put the key words. So their speech is mainly composed of maybe verbs and nouns and not many articles or prepositions. It's sort of a very hesitant, not a free-flowing type of speech pattern. Both those groups would have relatively intact visual spatial skills. Their memory is often quite good. So they could do most memory tasks quite well that an Alzheimer's patient would have severe deficits doing, whether it's remembering a list of words or a story you just told them.
So we have just a very few minutes, so I'm not going to spend a lot of time on this right now. But one of the most common types of frontotemporal dementia affects behavior. And in fact, behavior is a prominent symptom where memory problems or memory is more preserved initially. So you see these marked changes in behavior, and you have the information on your slides, so you can see that they might have poor judgment. They might go on spending sprees that the slide suggests. They become disinhibited or socially inappropriate, maybe going up and inappropriately touching a stranger or talking to strangers. They may have eating disorders where they start to want a lot of sugar, for example, and eat a lot of sweets. There may also be disinhibited sexual behavior where they're, again, interacting inappropriately, wanting sexual relations more often, exhibiting themselves in some way. You might see very repetitive stereotype behaviors. So I had a patient with frontotemporal dementia that hummed, and another one that sang a song repeatedly. Wandering a fixed route, hoarding, these are all behaviors you see. Also, they become less spontaneous, less involved in activities, have difficulty with control of their emotions. In fact, they become very emotionally flat and blunt over time and very indifferent, and it makes it actually very hard to care for them because they seem to have no emotional connection with their caregiver. They can become very restless, pacing, and have speech problems using repetitive words. And I'm not going to talk about this slide. It's information we've covered. It summarizes the difference between the three types of disorders. What I do want to mention is just a little bit about UCI Mind before we close off for this evening. UCI Mind is an organized research unit here on campus, and you can think about three different components of what we do. We do a lot of basic studies, basic science studies, in which we are looking at neurodegenerative disorders and the causes for them in animals. We have, for example, developed the first transgenic mouse model of Alzheimer's disease, a mouse that's genetically programmed to develop Alzheimer's, in which we do studies. We're now doing studies on stem cell therapy for Alzheimer's disease at an animal level. We have our Memory Assessment and Research Center, where we conduct memory assessments, but we also run a long-term research program that I'm going to mention, and then education and outreach, and you're experiencing some of that here tonight. So in terms of the Memory Assessment and Research Center, I want to particularly point out these opportunities to be involved in research. We are looking for both healthy older adults and people with very mild memory problems that want to come into our clinic and allow us to assess them on an annual basis and follow them across time until death. you heard us talk about this progression from normal aging to dementia. Well, we want to better understand that, and we do that by following people, by comparing people who remain healthy, cognitively intact until death versus those who developed MCI and Alzheimer's disease. We also ask these individuals to donate their brains upon death so that we can do some of the imaging type studies that you've seen. And we're also now starting to ask people to contribute their cerebral spinal fluid because we're looking for markers of Alzheimer's disease. So I just mentioned annual evaluations. We do ask that you have a family member that can come in with you, that can also talk about how you're doing, and brain donation unless there's a cultural or religious reason. We encourage people to do brain donation. We have over 300 participants. A couple of them are in this room that come in every year, and they love it because they get to talk to Dr. Dick and many other experts about how they're doing. They are following how they're doing, and the advantage is if something changes, our doctors pick that up right away and are able to then get you involved in the right treatment, maybe some clinical trials, so get to participate in studies you might not have access to otherwise. So at any rate, our staff is back there. If you're interested in participating in research, I'm going to ask that you fill out one of these cards that I gave you all earlier, which now is not one of these things. Even if you're on our mailing list already, if you need something from us, if you need us to follow up with you about something, or if you want to participate in our research program, fill one of these out and give them to the staff in the back. So we are really proud to be Orange County's only state and federally funded Alzheimer's disease center, and we're happy to be able to provide this education to you. So it is 7 o'clock. What I'm going to ask you to do is we'll take a couple of questions, and please fill out your evaluation forms. That information is very important to us. We take your feedback seriously, and we always try to improve our work. So does anybody have a question that they'd like to ask? Yes. The question is, does Parkinson's disease have vivid hallucinations?
Well, I think, yes, hallucinations can occur. It's also related to sometimes the medication that the patient is on. So some of the medications can also aggravate or cause hallucinations in very high doses.
Another question? Yes, right here.
Recently heard about coffee being also preventative for Alzheimer's. Is there any verification of that?
There are studies that show that drinking coffee regularly can have benefits for the brain. But I think the most important thing, and we are going to talk about this in November at our 4th session in lots of detail, but the most important thing you can do for your brain from the studies is exercise, physical exercise. There's a lot of little things that people are saying might be good for the brain, but the one with the most scientific evidence is getting out and taking a walk, a regular walk. That's
a question for Dr. Dick.
But
What time does the train leave?
to go listen to the band. But coffee has also actually been possibly shown as reducing risks for Parkinson's disease. So,
All right, way back there.
What about computer brain games, and what good are drugs like galantamine?
Well, I'm going to do the computer brain games, and he can do the drug, which I didn't recognize. Oh, what was the drug name?
galantamine.
Oh, galantamine. I didn't hear that right. We are finding evidence that cognitive stimulation can be very, very important. One of the things that happens, though, with computer brain games or doing a specific cognitive activity is you get better at the computer brain game, but you may not necessarily get better at other things. So cognitive stimulation is important. Cognitive, social, and physical activity are very important to your brain. And we continue to do studies to find out how to maximize the benefits of all of these.
Just our whole next presentation is going to be related to the medication issue, and so we are going to be talking about galantamine, or trade name is Razadyne, as well as donepezil, trade name Aricept, and ribostigmine, or Exelon. So we're going to spend the whole session really talking about what these drugs do, what are the benefits, you know, what are the limitations on them. So I think I'll just hold off on the rest of your question until then.
Okay, one more over here, and then we're gonna let everybody go, but we'll be here for a little bit.
Do I have to have somebody with me every time I come in?
If you are going to be a research participant, we ask that you have what we call an informant, and that person would come in with you for your annual visit. So they would help, we would be asking them some questions about how you're doing with your activities. It's like getting an objective outside opinion about how you're doing. And yes, we do require that for the research program.
Yeah, the term informant is a little unfortunate. It sounds like something from the East German government or something. So we prefer to use the term care partner.
Except if you're normal.
If
You
you're
don't
normal,
need
then
a
that
care
can be-
partner,
you
then
don't
you need
need
an
a-
informant. What can I say? Anyway, we're gonna let you go, but Malcolm and I will be here if anybody has any questions. And please visit our supporters here.